Hi and welcome everyone. I hope that you can hear me. If not, I will have a look at the chat. So if you have any technical difficulties, please feel free to let me know. Other than that, I would like to welcome you all to today's webinar about OccluSense. And I suggest we get started straight away. Okay. So my name is Mina Nicknazemi. I'm a dentist at the University Clinic of Cologne and also an OccluSense consultant at Bausch. And I am happy to speak about the subject OccluSense today, a new way to test occlusion. And as you can see, OccluSense is a product that has been established by Bausch, a company that has been dealing with occlusion control since 1953. And here in this video, you can see the production site and the headquarters based in Cologne by the Frühling Nazi. The company Bausch itself has been founded by Dr. Hans and Dr. Jean Bausch, so father and son, who worked with machineries, as you can see in this video, to produce a way to test occlusion in the patient's mouth. And today, this process has been automated quite a lot while still keeping the product quality very high. So the standard papers and foils, we all know because we use them in a dental practice on a daily basis. But today we want to look at a more digitalized manner to check the occlusion on our patients. And before doing this, I want you to briefly think about what occlusion is. So if you think about the concepts of static and dynamic occlusion and how you currently test these on your patients, we know that we have the foils and the papers in different colors at a width of 8 microns. And to look at a patient's occlusion on a dynamic basis and the static basic, you can check this with different colors. So you can use red for static occlusion, green and blue for medial and lateral occlusion, and black for protrusional movements. We all know that if this is a process that we have to repeat, it's a very, very time-consuming matter and takes up a lot of chair side time. This is exactly where the digital occlusion control, so OccluSense, comes into play. As you can see here, there's a test sensor that can be inserted into the handheld, and there's only one correct side. So since the pins and the holes are asymmetrically fitted to each other, there's only the correct way to really put this into the system. So there's nothing you can really do wrong. I'd like to say it's a bit idiot-proof. And you can then insert the sensor into your patient's mouth, and all the data of the movements will be transferred wirelessly to an iPad, where you can then check the movements and see the patient's markings in the patient's mouth. So as you saw in the previous video, the OccluSense system consists of a handheld with 2 buttons. I will go into the function of these in a moment, and the OccluSense iPad app together with the iPad, and the app is available on the Apple Store to download for free. Then we also have OccluSense sensors, which are currently available in 2 different sizes. So we have X and XL, and they differ in width rather than length. As you can see here, it's X and XL. They capture 256 different pressure levels, while still remaining only 60 microns thin, and with a material that's very thin and flexible. The red color coating, which you also know from the standard occlusion protocols with papers and foils, is also a very important factor that is still pertained within this method to test occlusion. So how does it work? For the initial setup, I've got a short video for you. So you ensure that your iPad is connected to your wireless network. Once this is done, you can open the app, the OccluSense app. You can see the logo over here. And once you're inside the application, you have access to your patient database. And within this patient database, you can then select the patient, as well as activate your system and do the initial setup, which you obviously only do once right at the beginning. I've got a short video for you to
open your OccluSense iPad app. Tap on menu item settings. Then choose.
So this is how you register your system.
To initiate the sensor test of the handheld has to be connected to the app first. Now go to settings in the OccluSense iPad app. Having your handheld and the test sensor ready. Now tap on Functionality Test Handheld. You will now be asked to insert the test sensor correctly and to close the sensor flap. The colored control button to start the function test. The function test starts now. The result of the function test is displayed in the app. Now remove the test sensor from the handheld and put it back in the storage box.
And this sensor test you do maybe once a day, depending on how often you use the machinery or the OccluSense. You don't have to do it before every usage of the handheld, but it's just to calibrate the system and ensure that you have highly accurate measurements each time. Okay, why do I need OccluSense? The best way to understand why OccluSense could be helpful within your daily activities in the dental practice is by comparing it to our current methods of occlusion control, so papers or foils. And if we take a look at this pathway, then you can see that in order to get from point 1 to point 3, so point 1 is the initial contact of antagonizing teeth, which then slide into intercuspidation before reaching the final maximum intercuspal position. This is a process that goes over time. So let's say in this example, you have 20 seconds. And in order to monitor this process very accurately and with all the level of detail that you really need, you need to monitor this for the entire 20 seconds and not just the end of it, which is what you would get with occlusion papers and foils. So you are able to take a look at point 3, so the maximum intercuspal position of occlusion when you're looking at it with papers and foils. So you can compare this with a snapshot of a picture in time, so of one moment in time that you can capture with this occlusion method. With OccluSense, however, you have the opportunity to check this process over time, go back and rewind, fast forward, and to look at this movement, which is what we are looking at, even for static occlusion, over and over again. So you can see what is happening initially on the antagonizing teeth. How do they slide into the final intercuspal position? And if you like, you can compare this to a video recording. So depending on the indication that you have, it makes sense to either take a picture or record a video over time. Do we really need that much information for the occlusion? If you take an implant as an example, we know that the threshold for tactile sensitivity of an implanted construction is about 8 times higher than the threshold of tactile sensitivity for a vital teeth within its natural periodont. And this is why any changes in the information that is passed over to your joints and to the nervous system within this entire system, it's very, very much harder to diagnose than it would be on vital teeth. So if we have a too high construction, for example, this would be much harder to diagnose. But implanted constructions aren't the only reasons why OccluSense makes sense. So you can look at hidden contacts. So if you have contacts that initially happen, premature contacts, you can easily diagnose them with OccluSense, as well as interference contacts you can look at. You can look at early detection of combined periodontal damages and incorrect loading, which is also quite important for ceramic chipping on implanted constructions, as well as look at the force distribution of the entire dental arch to also avoid chipping on crowns, on implanted construction, so anything that has a ceramic layer on top of it. And you can look at dynamic occlusion on splint and compare these recordings over time to track the muscle changes. What you also do is you're recording orthodontic changes and look at occlusion movements, as well as automatically documenting and using it for patient education. How do we use OccluSense? So as seen in the previous videos, you have a database with patients in there, and that database you obviously need to create yourself. So any patient that you want to have added in this database, you add them by pressing that plus button over there. And you can then enter the details such as first name, last name, gender, patient number, birth date. The patient number within OccluSense can be identical to the patient number that of the CRM system that you use, so that you can track each patient file back to the patient file in your CRM system. Once a patient is added to the database, you can then activate them by setting active, or if they have previously been there, you select them and you can open any past recordings. Once you're in the patient file, you can start a new recording by tapping new recording. And then you have the opportunity to adjust the time and frequency of the recording. You also can do this by using the button on the handheld. So the green button you can use to select the frequency, life mode, or adjust your frequency in general. And that's what it would look like once you're ready to get started. You insert the handheld into your patient's mouth. The use of Optragate is optional, so some prefer the use of it to have a clearer vision. Some find it a bit annoying because of the resistance of the silicone against the sensor, but I mean, it's a preferential thing. And then you can instruct your patient to conduct any movement that you want for static occlusion and also for dynamic occlusion. And in this video, you can see what it would look like analogly on your OccluSense. Here you see the markings left on the patient's teeth. So all that you are used to with standard papers and foils can also be transferred using the OccluSense. And this can then be transferred onto the OccluSense reading to look at the pressure intensity. You also have the opportunity to start the recording by pressing the pink start button on the handheld, and the device will then wait for the first occlusal contact before starting the pre-selected time. So you don't have to rush when you press start and quickly put on your gloves and then rush to the patient's mouth. So it's a bit smarter than that. Once the first occlusal contact has been detected, the time will start. And for more options, such as live recording, you can take a look at our manual, which will be delivered with the OccluSense starter pack, or you can download for free online. As you saw previously, there's a selection of colored columns at different heights in the interpretation of the OccluSense. And I want to talk to you about what they mean. So what the height of the columns tell you is more about the pressure and the size of the contact points. So if we have low columns, we have low pressure. If we have high columns, we have high pressure. So that makes sense, I believe. And now if you want to differentiate between the colors, you have to take a look at the area of the contact points. So green means we have a wider surface area that is being activated, and orange and yellow are something in between. So they're a smaller area, whilst red means we have a punctual contact. So the colors are more about the area of the contact that is being activated on the pressure sensor, and the height of the columns tells you more about the intensity of the pressure. We take a look at this bridge to try and understand what this really means. If you think about the load of this bridge that is being carried by the two pillars being transferred to the floor, you can see that on the left-hand side, we have a wider pillar that touches the floor. And this wider pillar transfers the same pressure as the right-hand side to the floor, but it has a bigger surface area. So then left with the bigger surface area to the floor is green. Right with the small surface area to the floor is red, but the amount of pressure that is being transferred for both pillars is identical, which is why the height of the pressures, the height of the columns is exactly the same. This is another example just to show you how the height of the columns and the colors are to be read. Do we need that much information for every single reading that we have? I mean, the movement of occlusion, and I call it movement on purpose because it's not just one position that is being found by the patient. It's actually, even for static occlusion, an entire movement that needs to be captured. And this movement consists of different pressures that are being applied to different areas of the teeth. And in order to interpret this in a very accurate manner, I want you to imagine that you're standing on a plate covered with needles, barefoot. And apart from the pain that you can feel in this moment, you can also sense that each of the needles that is being put pressure on puts a different amount of pressure on the sole of your foot. So each of those needles is being activated differently. And if we now take a little slide out of this needle plate and look at the activation of those individual needles, then you can see that on the very left-hand side, you have two needles with a high difference of activation on them. This is because the pressure difference between those activated needles, so the two, is very high, which is why this is red. And orange and yellow in the middle, you have less activation. So you have a different color, whilst for green, where the needles that are next to each other are activated in a similar way, they then are colored, marked in green. So what I want to tell you with this is that you always need to remember when you are looking at your OccluSense reading that the sensor and the pixels on that sensor are constantly being compared to one another. So if the pixels in a neighborhood are being activated in roughly the same manner and have the same pressure being put on them, then that area will be shown green. But if we have an area of pixels in the neighborhood where two needles, for example, have a lot of pressure being put on them, and the neighboring needles very little, we know that this is a punctual contact. So that's why this is coded in red. Just to summarize this again, when we have red color markings, this means we have high spots of contacts. It could mean that there's initial occlusal contacts and also standalone contacts that are not in full intercuspidation. Whilst green color markings usually stand for a more surfaced area contact, and this can be the case for abrasive teeth or areas of contacts with a similar pressure. And everything in between literally means it's just something in between. But what you do need to remember is that they are neighbors in a neighborhood and they are being compared to one another constantly. So this is actually a relative reading, and it doesn't give you uh, a unit for pressure, but a relative percentage of how much pressure is being put on somewhere, as you can see over here. Let's take a look at this example for static occlusion and have a go at trying reading this yourself. So initially what you can see immediately is that in the right molar region, we don't have a lot of red points. So this could actually mean, okay, so if there's no red, we don't have high pressure there. But in fact, that is not the case. If you take a look at this quadrant percentage reading on the side of the scalings, then you can see that actually 44%, so this is 23 and 21%, 44% of the entire pressure within this dental arch are located in the right molar region. Only because we don't have any red points there, or not many, it means that we don't have a lot of punctual contacts. So the contact points, the type of the contacts are more surfaced. The surface area is wider, but the amount of pressure that's being applied there is higher than anywhere else. And this is how you should be reading this. Exactly the same. You can obviously do for dynamic occlusion. So here you can see the static occlusion, and then we slide to the left for lateral protrusion to the left, with going back and sliding to the right, lateral protrusion to the right. And you see here that in the left molar region, we actually have a premature contact that is also antagonizing this movement. So if you're looking for a canine guidance, maybe you don't want that contact there. There's a few features on the app that I want to also display to you very shortly. So you can switch between the viewing options, between two-dimensional that you can see here and a three-dimensional option, which gives you the opportunity to look at the height of the columns as well. But if, like me, you want all the information on one screen, you can also use a combined viewing option. Other than that, we have additional controls. So as said, you can amend your viewing option by going into full screen, combine your views, and twist and turn by using your finger. What you can also do is go ahead and pause, speed, rewind any recording that you have made. You can also do some noise cancelling. So as mentioned, you capture 256 different pressure levels. But if you feel like maybe this is too much for this treatment, and you only want to look at very relevant, highly, obvious contacts, then you can, for example, only look at 200 pressure levels to try and filter to only what you need to see. You can also split your viewing into percentiles and quartiles and also compare two recordings over time. This is quite important for orthodontic changes or for splint therapy to try and look at what your muscular activity or what role your muscular activity played in your patient's CMD, for example. To give you more of an insight into the noise cancelling, you see here that on the left side, it's filtered to only 30 levels. Right side, you see 40 levels, and then it kind of shows you how you filter out only the important points. What you can also do is export data, so either via PDF or PNG, and you do need to go into full screen mode in order to do so, because only in full screen mode, the button for exporting will be then shown to you, and it will then prompt you and ask if you want to export PDF into your Files app on your iPad or PNG into the camera roll. So in this way, you can take snapshots and kind of export these out. If you want to export an entire video, you need to start again within full screen mode, your screen recording. And if your microphone is activated, any audio comments that you make and also any movement that you make to the viewing options with your finger will also be recorded until you press stop. And then you can share this into your camera roll, and this way you can also export a video. We also have a network access guide for some of the IT geeks. I'd like you to take a look at this online because I can't be going into all the technicalities, even if I wanted to. All right, so how do we get started on our patients clinically? In order to trace back the reading of the OccluSense, so the columns, into your patient's mouth, you need to ensure that when you are taking the recording, the red triangle at the bottom of the sensor, so this is the midline, is also inserted into the midline of your patient's mouth. And once this is the case, then your midline is also in your OccluSense reading, and you can then trace back every marking on your patient's teeth into the columns on the OccluSense reading. And the scalings on the side of the sensor can also be identically transferred over so that you can trace back the markings also within these segments. Let's try and read these OccluSense information on the clinical data and on our OccluSense reading. If you look at the blue circles in the clinical view and also in our 2-dimensional and 3-dimensional OccluSense reading, then this is a occlusion on a molar, which is very regular. So we have a very normal punctual contact in this area with a good pressure, which we do want to have there. In the orange circle, you can see exactly the same for premolars. So we have a normal contact on a premolar. And in the purple circle, you see a premature contact. Okay, how do I know this? Why do I know this is premature? Number one, if you look at the clinical view of tooth 36, then you can see that on this molar, the mesiobuccal contact is one that's very strong and it's not supposed to be there. So this is already something, when I look into my patient's mouth and I see any color markings on the buccal lower jaw teeth, and this is something that immediately catches my attention. And when you then look at the OccluSense reading, you can see that the left molar quadrant is orange So we have 50% of the entire pressure of the dental arch being located right there. So I already know something is not right there. And this also enhances the clinical view of the wrongfully placed color marking in the patient's mouth. The same you can do with dynamic occlusion. So here you see lateral protrusion to the left, where you have a group guidance, which is not ideal for patients with a full dental status. And the same obviously with protrusion. Okay, so I've brought to you today a few clinical cases that we can also take a look at from a few patients that I want you to analyze. So this is a female patient who presented herself with symptoms such as ringing in her ear. She had the feeling there was some cotton inside there, so some kind of blockage, and cervical spine with ligament sheath prolapse. A few more pictures of her clinical situation. So you can see quite a few restorations also in place here. Further to her symptoms, she also had a hyperactive thyroid gland and some muscle tension in her face between nose and ear. When we then looked at her static occlusion with OccluSense, we very, very easily were able to spot the primary pre-contact on 48. Then there's an unequal load in intercostal position, as well as a final heavy load between 41 and 45 at the end of the movement. This is a static occlusion. And her protrusion showed a parafunctional contact on 48, which also prevailed on her medial protrusion to the left, where she showed no canine guidance. To the right-hand side, she did have some group guidance, but again, parafunctionality on 48 and 38. So we can see that tooth 38 is, yeah, showing up quite a lot. Her bruxism contacts then showed main movement over 43, but again, prevailing parafunctionality on 48. And looking at her nocturnal movement with the OccluSense spray and making a recording in centric position, we saw that within her centric position, she also had a premature contact on 48 and very, very small changes in this contact area. So adjusting her occlusion on tooth 48 and reducing the pressure in that area a little bit actually led to her symptoms that she initially presented herself with to fully heal. The next case I've brought to you is quite a simple case where I just want to take a look at very standard occlusion as well, because we don't always have to have any symptoms to use our OccluSense to try and look at the patient's occlusion. The static occlusion was very much evened out. And here you can see her lateral protrusion to the left-hand side with the, oh, my finger is a bit too fast for my system. Let's go back. Okay, this one we already looked at. Case number 2, now showing a very standardized way to check the occlusion of a patient. This you can actually integrate in your normal control appointments. Here you can see the static occlusion of the patient, which is very easily evened out. Don't be weirded out by the absence of any contact points in the right molar area. In the fourth quadrant, we are missing some antagonizing teeth, which is why there's no pressure detected in this area. And the same can be done for lateral protrusional movements. So here in this reading, you see the lateral occlusion to the left-hand side with a very beautiful marking on the canine of the left upper jaw. And another view of the protrusion of this patient. The final case I've got for you today is OccluSense and splint therapy. And here I'd like you to take a look at the condylar processes on the left and right-hand side of this patient. You can see that they have a very different development. So it's actually a case of hemimandibular hyperplasia. And this patient chose no surgical intervention, which is why our aim within this treatment was to try and fit a night guard that can protect the teeth and the mandibular joint, because she actually presented herself with a lot of teeth grinding overnight. So this is a static occlusion without a night guard. And what I want you to look at is her occlusion without any night guard fitted. So this is a standard occlusion in a static position. Please take a look at all the occlusal interferences and also the force distribution. What is easily seen here, if you go to the beginning of the static occlusal movement, you merely have contact points in the right molar region. This is because the patient, due to the differing development of the condyles left and right, has developed an open bite on the left-hand side. You can see this in the next clinical picture as well, and you also see this here. So she has an open bite on the left-hand side, and with sliding and gliding, her contacts move more into place, but they are still not evenly distributed. You see that there's quite some pressure interferences within her quadrants. And so this is a static occlusion without the night guard. And I want you to think about how you check your patient's occlusion when you fit them a night guard. So what we usually do is we take a piece of premolar wide shim stock foil, and then we go into all the areas where we expect a occlusal contact. So two molar contacts on the right hand side, then two premolar contacts on the right hand side again, then the front, and then we go right through the left to the back, and we try and receive the same resistance when pulling out the shim stock foil everywhere. And this is how you roughly check that your occlusion is evenly distributed in our dental practice. It's number one, a very time-consuming matter. And number two, when you do this, the resistance you pull your shim stock foil out with is always different. You cannot ensure that this resistance is the same. Also, the resistance that you feel when pulling out always feels different. You cannot ensure that the feeling that you have is also always the same. So this type of occlusion measurement and control is very subjective and not really something that can be carried out in an accurate manner each time. And this is what we did with this patient. So when we fitted her night guard, we checked her occlusion with shim stock foil, and it was roughly evenly distributed. So we then scheduled her for a checkup appointment a couple of weeks later, where she presented herself with quite some joint pains, which is why we then looked at her occlusion with OccluSense. And now you can see also here in the clinical view on the left-hand side, the open bite very nicely. And I want you to look at her occlusion with the night guard fitted. I'm purposely going to pause this right at the end, because you can see here that in every single area that I mentioned earlier, where you would put your shim stock foil in, you will receive some kind of resistance. And you will then think that the occlusion is evenly distributed. But if you look at the OccluSense reading more closely, you can see that even though we have contact points everywhere, they're not really evenly distributed. So in the front on the right-hand side, we have quite some increase of pressure. And if you look at the beginning of her movement, oh, I'm so sorry. If you look at the beginning of this static occlusion movement, then you can also see that this is definitely very unevenly distributed at the start, and then via sliding and gliding again, this then goes into a different final draw position where your shim stock foil would show you some contact points everywhere, but with OccluSense you can see that this is not actually the case. And exactly the same you can do then for dynamic occlusion movement. So with this splint, we did a fabrication at the front to achieve some canine guidance. And also here you can see that this movement is carried out due to the abrasiveness of her canines is carried out by only the front. So this also needs to be fabricated to give you a more evened out canine and front guidance. Protrusion also showed that this movement was carried by only a single tooth, so this also needed to be fabricated slightly. So maybe the most relevant question for you right now is, does OccluSense replace the articulating papers and foils that we use in our in today's dental practice? It really depends on the indication. So if you want to take a snapshot of a single moment in time, use papers and foils. If you want to take a video recording over a period of time, use OccluSense. So it really depends on the type of treatment that you're carrying out and the level of information that you want to receive from your occlusion protocol. What I personally would recommend, so this is the algorithm that I usually use. I use OccluSense before to check for premature contacts, to look at the pressure distribution and give me a very quick overview and feeling of the occlusion in the patient. I then do fine adjustments with papers and foils, and then I check my final result with OccluSense again. What you're also automatically doing is you're documenting everything. I'm not actually the only user of OccluSense on this planet. So all over the world, we have different dental professionals which have specialized in various specialities, such as implants, such as craniomandibular dysfunctions, those that do conservative dentistry, such as fillings and endodontal treatments, who also use OccluSense to ensure that the occlusion within their patients is ideally distributed. To get started with OccluSense, what you need is an iPad. All versions produced in 2014 and later are supported. You then need the iPad app, which is free to be downloaded in the Apple Store and currently available in 12 different languages. You need a functioning Wi-Fi connection and the OccluSense system BK5000, which gives you a starter pack with everything that you need to get started. So that is actually all from my side. Thank you very much for your attention and your time on this beautiful Saturday. I've blended in my contact details as well as my LinkedIn. If you like to get connected with me, then feel free to do so. If you have any questions further down the line that you can't think of today, or you're using OccluSense, you're not sure about a specific patient case, then feel free to drop me an email or a LinkedIn, and then we can, I'm happy to discuss any open questions that you have. And for now, I'm open for any questions that have already arisen. Or arisen, I think, the correct way to say this. feel free to note them down in the chat or open up your mic and just drop any open questions into the microphone. Okay. All right then. Thank you very much for joining me today and for your attention. As mentioned, note down my email address. If you can think of anything in the future, feel free to drop me an email. And if not, then I wish you a very nice weekend and hope that you enjoyed today's little overview of OccluSense with me today. All right then. Goodbye.